This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2013, all rights reserved. Your moderator today is Greg Spratt. He is a respiratory therapist, the Director of Clinical Marketing for Covidien, and the Chair of the Ad Hoc Committee to Reduce Hospital Readmissions. He welcomes you to today's presentation, COPD Best Practices. With the looming implementation of the Affordable Care Act and the readmissions penalties and payment reductions expected to challenge the profession, the sharing of best practices will be instrumental in how we serve our COPD population. 4 different programs will be highlighted in this special presentation. Upon completion of this AARC webcast, the participant will be able to define components of successful COPD management programs, identify methods of planning for and operationalizing a successful COPD management program, discuss ways to promote a COPD disease management program to hospital administrators and community leaders, and identify appropriate metrics to measure the success of a COPD disease management program. And Greg, I'll turn it over to you.
None of today's speakers have a conflict of interest related to this presentation. I disclose that I am an employee of Covidien. Brand names of products may be mentioned only as examples of technology. Our first speaker today is Becky Anderson. Becky is a respiratory therapist and was the first RT COPD clinical specialist when Sanford began its inpatient COPD program in 2008. She is currently the manager of the Disease Management Group and Respiratory Care Services at Sanford Medical Center in Fargo, North Dakota.
Thanks, Greg. Good afternoon, everyone. Today, I will be sharing with you the essential components of Sanford's COPD inpatient care program. Sanford Health is the largest rural, not-for-profit healthcare system in the nation, and our inpatient COPD care program is the culmination of a respiratory therapy-led initiative at Sanford Medical Center in Fargo, North Dakota, which is a 2-campus, 583-bed tertiary teaching hospital. The first step in building our program was to align with our organization's strategic initiatives. In 2007, the hospital vice presidents asked for help in reducing cost of care for medical patients, and in addition, our integrated health system had identified evidence-based chronic disease management as a vision item on our 5-year plan. A DRG analysis showed we were indeed losing money on COPD admissions, and in addition, we knew quality of care might be an issue as there were no clinical pathways or standing order sets for COPD admissions. We knew that respiratory therapy could have a positive impact in the cost and the care of COPD inpatients. Our next step was to evaluate the degree of evidence-based care that we were providing. We utilized a study published in 2006 in the Annals of Internal Medicine where Dr. Peter Lindenauer and his colleagues retrospectively reviewed the financial records of almost 70,000 patients across the country who had been admitted to hospitals with acute exacerbation of COPD. And they compared the charges from those financial records to guidelines from the American College of Physicians and the American College of Chest Physicians. And from there, they identified the level of recommended care, non-recommended care, and what they called ideal care. To identify to what degree we were providing evidence-based care, we chose to replicate the Lindenauer study. And by using the charges from financial records of 244 patients admitted within the previous 18 months, we found that we were lower than the national average in providing recommended cares. And those cares are listed on this slide. In addition, we were better than the national average in non-beneficial cares, which are considered wasteful. Finally, we were just average in ideal care, which is described as having received all the recommended cares and none of the non-recommended cares. So there was certainly room for improvement in the quality of care for our COPD patients. A quarterly financial report identifying patients coded under the COPD MSDRGs provides the base for many of our outcomes measurements that we do. This financial report includes things like length of stay, charges, estimated reimbursement, direct and indirect costs, total cost, and estimated net margin for each patient. And we also identify payer mix and department costs per case. And the reference values for reimbursement and length of stay for all DRGs are available through CMS, and that's the table that you see on the bottom, the payment and the geometric mean length of stay for the 3 COPD DRGs and the acute respiratory failure DRG. Another important component in developing our program was identifying project champions. A hallmark of our program is that while this is a respiratory therapy-led program, development and steering are provided by an interdisciplinary advisory team from across hospital services. Our pulmonologists and hospitalists, our clinical pharmacists, as well as respiratory therapy were instrumental in drafting and completing some of the tools we use to provide the care, and we'll take a look at those tools right now. We had no standing order sets for COPD admissions, and practice varied a great deal among our hospitalists, so building an admissions order set was a priority in program development. And we made sure we included the recommended cares that we just looked at as part of the order set. And when we provided education to the physician and respiratory therapy groups, we included the evidential background upon which these choices were based. The evidence included the following. We used a 2008 meta-analysis published in CHEST that stated that corticosteroids, antibiotics, and non-invasive ventilation were all very important in managing COPD exacerbation in the hospital. As you see on this slide, corticosteroids reduce treatment failure, reduce length of stay, and oral is as effective as systemic, which is important consideration because the cost of IV steroids was 10 times that of oral steroids when we began our program. Antibiotics reduce treatment failure and hospital mortality, while non-invasive ventilation reduces the need for intubation. So it's no surprise that non-invasive ventilation also reduces mortality because intubation is the leading indicator of hospital mortality. When COPD is added to CMS's hospital value-based purchasing program in fiscal year 2015, the outcome measure will likely be mortality. It was also important to us that the admission order set includes orders for the respiratory therapy protocols. We've worked under a protocol system for about 25 years, a consult for our COPD specialist, and a tobacco education consult for patients who have used tobacco in the past 12 months. Another evidence-based tool developed by the COPD Inpatient Steering Committee was the Respiratory Therapy COPD Medication Protocol. The goals of the COPD medication protocol are to provide bronchodilator therapy with the frequency and dosing based on patient symptoms. We use short-acting bronchodilators to aggressively bring exacerbations under control, and then we maintain control using long-acting bronchodilators, thereby reducing cost per stay. The evidence shows that the use of long-acting bronchodilators both reduces cost and reduces adverse events for patients. The protocol steps include the following. We discontinue all the home inhaled medications on admission and start albuterol and ipratropium with the frequency determined by patient symptoms, including breath sounds and dyspnea, as the patient's perceived dyspnea level. Those symptoms are given numerical values which are added together. That score is then used to determine frequency of treatments. Most of our patients are on the short-acting bronchodilators at a frequency of every 4 hours for the first 24 hours. And when a patient is in the 3 to 4 score range, the therapist can then evaluate to move to long-acting bronchodilators. When the decision is made to move to long-acting bronchodilators, the therapist measures an inspiratory flow to determine whether the patient should receive the meds by DPI or by nebulization. And an order for albuterol as needed reassures our patients that even when they're on the long-acting bronchodilators, which in the beginning a lot of them were not, and so this was a real reassurance that they could have albuterol any time of the day or night during their entire hospital stay, that the therapist would be available to see them whenever they needed them. These next few slides show the work we did on understanding the cost of medications per treatment. Labor cost for the professional should also be included in any of these calculations, and our costing department was able to give us that information. We look at cost per puff, cost per unit dose. If you're doing common canister, then you want to know what the cost per puff is. If you're not using common canister but using MDIs or DPIs, you need to pay for the total cost of the device. So you need to know what those costs are. Another important component of our program is the use of respiratory therapy case managers. By utilizing evidence-based care to reduce treatments per patient stay, we were able to redeploy RTs to serve as case managers for patients admitted with COPD exacerbation. And our COPD clinical specialists provide inpatient case management, they provide patient education, and they facilitate patient engagement and transitions of care. These RTs serve as both physician extenders and patient navigators, and they have really a profound impact on our outcomes. Identifying, recording, and monitoring outcomes are another key building block in our program. Outcomes allow us to monitor program effectiveness and pinpoint quality improvement opportunities. So, speaking of outcomes, this is our outcomes for the percent of patients who receive all of the recommended cares. We monitored this outcome. When we began, we were less than the national average, and now we are above 90%. And remember, recommended cares reduce treatment failure, decrease length of stay, and decrease mortality. Again, when we began, our net margin was negative $500 to $600, which that time period would be to the left of this graph as you face it. And that was 18 months to prior to starting our program. Within that time frame, we were losing $500 to $600 per patient stay. And you can see that we have improved to an average net margin of $1,000 per patient stay. For us, that is a positive swing of about $250,000 a year. We have 2 COPD clinical specialists, case managers, working 1.6 FTEs. They do not make $250,000 a year. So good outcomes, financial outcomes for our hospital. For readmissions data, we use a product called Crimson, and your organizations may have other products such as UHM, Midas, McKesson, or a few of those products. This graph shows Sanford's 30-day all-cause readmissions when the index admission was COPD acute exacerbation. The blue bars represent Sanford's readmission rate by percent. The gray dots are the comparison top decile of Crimson users. Our pre-program readmission rates were about 24 to 34%, and we see an immediate impact when the program began the end of 2008. And our quarterly readmission rates have been as low as single digits, as you'll see on that graph. But look what happens to us over the next 2 years. In 2011, we saw our readmission rate increase significantly, and a big part of this increase was due to 2 patients with challenging socioeconomic needs who experienced high hospital service rates that year. One patient had 31 ED visits and 12 hospitalizations. The yellow triangles show our readmission rates after removing those 2 patients, moving us back to the same or better than the top decile. While a little distressing, we saw that this data was an opportunity to address a care process which had not been clearly defined and which included the ED, the hospital, case management, and the respiratory therapy clinical specialists. While the CMS penalty is tied to 30-day all-cause readmissions, we also like to know what our same-cause readmissions are doing. The blue bars on this graph represent 1 or 2 patients per quarter who are readmitted for COPD exacerbation when the index admission was also COPD exacerbation. And pulmonary rehab referrals are an integral part of our discharge process. In 2008 through 2011, for the 104 patients who completed phase 2 of our pulmonary rehab, we had a 47% reduction in emergency room admissions and a 68% reduction in hospital admissions when comparing the 6 months of pre-program and post-discharge from pulmonary rehab phase 2. Aligning with our organization's strategic initiatives was a very important first step, and for us that meant improving quality of care and reducing cost. Today we are also aligned with CMS's mandates to reduce unplanned readmissions and hopefully to meet the anticipated measures for the hospital value-based purchasing program when COPD is added in 2015. We have developed the tools to provide evidence-based care, which reduced cost and allowed us to redeploy therapists as case managers. In addition, we've developed a wide range of partnerships with the patient, the hospital, ambulatory services that helps to facilitate seamless transitions. Respiratory therapists are so uniquely qualified to provide coordination and care for COPD patients, and we are truly at a unique time in healthcare history that makes our expertise an important part of transforming healthcare. And with that, I'll turn it back over to you, Shauna.
Thank you very much, Becky. That was fantastic. We do have a couple of questions. First off, there's a question about your NEB-MED protocol for determining frequency. Did you use a tool that was already validated, or did you use a tool and then have to validate it internally?
The tool that we used, I believe, was not validated, and we took parts of several different tools and put them together. At this time, we have not yet gone through the validation process internally, which is something we need to do in the near future, but simply because our health organization has gone through some huge changes in the last few years that have kept some of where we need to go kind of on the back burner, and one of them is validating this item.
Fantastic. And then I have a question for you about your respiratory therapy department. How did the department as a whole receive or buy into this kind of a project? You know, this is a lot of change. How did they adapt to that?
I would say that we had a wide variation of adaptation. We had some therapists who understood the implications of what we were doing, who jumped right in, who were so excited. Some therapists who had seen things come and go and were wondering if this was just another flash in the pan. I think some of the important pieces that we went through as a department and that were pre-existing is, number one, we had been working with protocols already for 20 years. So a protocol to a therapist in our department wasn't something new, wasn't a new way to do work. However, this specific protocol and this specific program essentially asked the therapists to work at a higher level within their scope, because although I haven't mentioned it, the staff therapists are an exceedingly important part of care for our patients and for our outcomes. They work very closely with our case managers in addressing needs of the patient. We did education for staff. We answered questions. I think my whole first year trying to move the outcomes, improving the outcomes, was very slow, in part because I was working on getting buy-in and creating new habits for both the respiratory therapists and the physicians. We, every year, at least once a year, again, update our therapists, and certainly some of the praise for the great outcomes we have is attributed to them. So we want them to know that we appreciate the work they do.
Thank you. And I have time for just one more question. And I think this is kind of a question that's on everybody's mind as we move forward with this new age of having the responsibility of and taking the consequences of the readmissions when you have patients who are not compliant. How do you deal with the problem patients, and I use air quotes here, problem patients that refuse to stop smoking, failure to follow their diet, or whatever you've recommended? How do you deal with those kinds of patients?
Well, a prime example is one of those patients that greatly impacted our readmissions in 2011. That specific patient, as I said, big socioeconomic issues that we had to work out. In our opinion, most non-compliance is what we call non-adherence, and much of it comes from not understanding, not being able to afford, not having transportation, and just depression, anxiety, so on and so forth. With that specific patient, we gathered the team, and the team was the patient, her family, the emergency room, the hospital, the case managers, the respiratory therapy case managers, all ambulatory services. She had been fired from 2 home care companies. We all got together several times, and with the patient we drew up a contract. And there were specific things that she needed to agree to so that we could all move forward. One of the biggest things is she lived up 9 steps in an apartment and couldn't get to any of her appointments. Her family wasn't able to be around much. She, after building this trust, this was over a period of probably several months, building trust that we wanted to do what she wanted to do, and she wanted to feel better. She decided to move to a nursing home. So again, building trust is essential, and this is along a continuum of a disease. It's not a point in time. So making sure that everybody across the continuum knows what the care plan is exceedingly important.
Thank you very much, Becky. Greg?
Thank you, Shauna, and thank you, Becky. Our second speaker is Karen Schell. Dr. Schell is the Director of Cardiopulmonary Services Department at Newman Regional Health in Emporia, Kansas. The department staff covers all aspects of care and staffs respiratory therapy, cardiac rehab, sleep lab, pulmonary function lab, EKG, and pacemaker clinic. The program at Newman Regional Health was developed to improve patient care from admission to dismissal and impact COPD readmission rates under the primary care therapist model. Karen?
Thank you, Greg. I want to welcome everyone to this meeting this afternoon. I'm a little bit hoarse, so please bear with me. I wanted to just start with a little bit about Newman Regional Health here in Emporia, Kansas. We're what's known kind of as an in-between hospital. We're a smaller hospital located in the south central part of Kansas, and we service about 7 counties surrounding us. We're in between 2 larger communities, Wichita, Topeka, and Kansas City. So we really are an in-between hospital, but we do have a large population of patients. A little bit about those patients. Most of them are rural patients, and we know from past experience about 64% of those patients are Medicare patients. And as we look at our department specifically, cardiopulmonary services actually employs 14 employees, and we cover the hospital 24 hours a day, 7 days a week. And actually we use about 2.5 FTEs in our cardiac rehab and sleep combined, and the rest 9 FTEs are included in the respiratory care, cross-trained across those various departments. And that includes myself and my clinical supervisor. One thing that we started to look at as a community hospital a few years ago is our financial situation has been very difficult to maintain, again, because we're a smaller hospital in between 2 larger communities. We have a lot of charity care, a lot of self-pay patients, and also those patients that are Medicare patients. So the reimbursement there isn't there. But we know how important it is to provide the care for our community within the reaches of those 7 counties, because we're a local hospital. We're a county hospital only in name only. Basically, we're governed by a board of directors, but we're totally financially dependent upon our patients. So just a little bit of background there. I wanted to get into a little bit about how we got started on this path. And let me just move this forward. As with many of you, we use the AERC a lot of times for educational purposes, and I've been attending AERC meetings for a long time and benefited greatly from speakers just as Becky, listening to what they're doing in other communities. But because we're a small community, I had to try to figure out a way for us as a small staff to provide that service to our area patients. So we thought about how we could do that. So we wanted to find a problem and then build a plan around it. And what we decided to do was to start small and to build on our successes and get involved in a lot of the different aspects of care in the hospital itself, be involved in the committees, be involved in opportunities that we can let them know that we have the expertise and we can help develop some of these plans. We wanted to gain confidence not only of our peers and our other department directors and other department staff, but also of our patients. So we wanted to get involved. We wanted to build some allies. We wanted to be involved with the nursing department, with the physicians, with the quality and the risk management. We wanted to be able to use our available resources, such as our charting, Meditech, unit-based councils, IT department. We wanted to improve our staff skills and be able to cross-train because we do cover so many different areas 24 hours a day, 7 days a week. We needed expertise in each of our therapists. We wanted, by do that, demonstrate competence by making sure all of our staff participates in ACLS, PALS, NRP, stable, and hazmat training. We wanted to build those relationships with other areas of service, including the patients and the families and the community itself, along with other departments and their directors. How do we want to do that? We want to improve the processes that are in place. As you know, many of the changes going on, it's difficult to have a good process, and we wanted to streamline those and be able to use the resources we have to improve our processes. And then we took a look at ourselves and said, what can we do with the staff we have? Because of our financial restraints, it's difficult to find, be able to hire anybody. And we knew that this would all take a lot of time because we are a small staff and cover a lot of things. And in a small hospital, a lot of things can happen in one day, and just staff availability was going to be difficult. So as we moved on and looked at what we did, we decided to look at problems that we recognized on all of our admissions that we can make the biggest impact on. And we decided to focus on three major things: smoking cessation counseling, obstructive apnea screening, and COPD respiratory education. Because a few years ago, we looked at developing a COPD case manager, and we had actually applied for a grant from the government to help implement those services with some funding, but we weren't picked for that, and we knew that we didn't have the funds to actually provide a staff person for that, so we decided to take the approach that all of our staff would be involved in it. And we know that smoking cessation counseling, obstructive sleep apnea screening, and COPD education all impact patient care, their readmission rates, and also the quality of life. So how did we get started? Well, my clinical supervisor and I sat down and asked ourselves three questions. What could we be accomplished with the staff and the resources we have available? What staff skills did we have? What did we need to work on? How many FTEs would it take? And how could we get this implemented? We also looked at how could we get the staff up to speed quickly with the increased time needed and with the FTEs we had. We know because it takes time to build a staff and be able to build their skills. We know we needed to commit to education. We needed to improve their communication skills because it would be key to success is that they can sit down and talk and develop a plan with a patient or with a physician. And we knew that this would all take time to do. And did our staff have the expertise and motivation to add more to their day? We're pretty busy during the day. We're a small staff when we have a lot to do, and there's a lot of time. There's not a lot of time to be able to sit down and recognize what we need to get established. So how are we going to do that? So we looked at several ways how we would get started. And at about the same time that all of this happened, we started at the hospital as a hospital initiative for relationship-based care. And at that time, and if you're not familiar with it, it focuses on at the patient's bedside. Everyone is focused on patient care, and primary nursing was being developed with unit-based councils to empower employees to be at the bedside and take care of the patient. And we decided that we could accomplish all these three initiatives that we talked about with the development of a primary care therapist, where each of our therapists became a primary care therapist. So we decided we would take small steps by easing the staff into the idea and starting off with developing staff skills, one objective at a time. And then we would initiate the primary care therapist in steps over a 6 to 12-month period. So we actually started with our program, our first initiative, with the smoking cessation counseling. We knew that smokers were already being identified on admission through the nurse assessment, and they simply, when they did their admission screen, they asked if they were smokers or non-smokers, if they were interested in quitting, and that actually went into the database in Meditech, but there was no way for us to pull it out to see who were smokers or not. We identified smokers when we had them on breathing treatments, and were able to talk to them, but those patients that weren't on breathing treatments, we wanted to be a way to get a hold of them when they're in the hospital and offer them opportunity to quit smoking. So we used relationships and resources and had to build a report in Meditech to identify all the smokers on admission, and that those would be compiled, be sent to our CPS printer. So every time a nurse does an admission and if they say they are a smoker, it comes down to our printer, and actually since then we have built it so it comes to our email, so we know every smoker that enters the hospital. We actually then started training staff to counsel patients on the benefit of quit smoking, and using resources already available, particularly the one from the AARC, the Smoking Cessation Guide for Therapists, and we used that tool to take. We also collaborated at the time. We had the opportunity to be part of a research project with the KU in the Can Quit program, in which we identified smokers and let them be able to counsel them by phone after they were dismissed. So that worked really well into our project, and it also helped with the patient after dismissal because they were contacted by KU and given free counseling on how to quit. We also had all the smokers addressed by a trained respiratory therapist. And this not only helped with identifying smokers and getting them the resources, it improved our staff's ability to do patient education at the bedside. And it put the staff at the bedside more frequently caring for the patient. A lot of our therapists were uncomfortable with that interview process, and so this was kind of a foot in the door on how to get started on patient education. We had developed the training, they had the resources, they went to the bedside and they talked to the patient. This also prepared the patient, the staff to be a patient advocate. It helped them identify weaknesses with those patients, that perhaps they weren't taking their medicine right, perhaps they had quit smoking and restarted again. Again, this helped improve their patient relationships and improve the staff's confidence level in the ability to counsel a patient. And I think when we go to respiratory school, that's one of the things that we don't do frequently, is learn how to talk to the patient and how to interview, those interview skills. So that was our first step. Then we moved on to our second initiative, and the problem here which developed with obstructive sleep apnea screening is that patients were not being identified at risk by nursing, and often they got into trouble during the hospital stay because RT was not at the bedside until the problem occurred. We had patients come in that had obvious sleep apnea, but they weren't treated until they defatted or had a problem, and then respiratory was called. So we wanted to identify those patients up front and get them on the right track. While what happened when they were identified and defatted, then they ended up having longer length of stay because of that problem. So we wanted to identify those patients up front with a screening tool, and so we wanted to implement that again with the nurse admission. And we had the Meditech again with our relationships built before with the IT personnel, a screen built with the RT initiatives in Meditech with the Stop Bang questionnaire, and that report actually comes to the CPS printer 3 times a day, different times of the day, so that we can see all admissions within the first 24 hours of patients that may be at risk for high sleep apnea. So again, those patients are identified at our printer. Our therapists divide it up and go upstairs with information to that patient. The staff comes to their room, educates the patient and the nursing staff, as well as the physician, about the positive screen of the Stop Bang. And if it's applicable, then we have intensive monitoring on that patient. We actually mark the room that this patient is at risk for sleep apnea. We label them with a high risk, and also the nurses notify them to be aware of this patient during sleep. If applicable, then we also start patients on auto titrate CPAP. We went to the physicians and got protocols started where if we have a patient in trouble, we can automatically put them on a CPAP. And also what helped us identify those patients that had already been through the sleep lab that have home CPAPs that were coming into the hospital without them. Their perspective was they're going to the hospital, they don't need their CPAP machine. So we, again, we don't have enough equipment to go around for all those patients, so we implemented a program to set up home CPAP machines where the RTs inspect the machine and help the patient get started on that piece of equipment while they're here at the hospital. This helped us not only with identifying those high-risk patients, but also fast-track the patient into the sleep lab or to see the sleep physician if necessary. We had an automatic process where we notify the physician and they can do a direct referral or refer them to the sleep lab. So again, we're catching all those patients that may have been overlooked before, and we're preventing the length of stay because they had a DFAT or an incident happen while they're here at the hospital. Again, this works towards improving the staff communication and assessment skills. It builds their morale because they have the confidence and the skills to do that, and it improves our patient care. Our next step that we started out with, did I go past the slide? Hold on. Was to roll out our primary care therapist. Again, the whole hospital was going to relationship-based care, and we felt as a therapist, we needed to be involved in that. There was primary nursing, and we felt like we had the expertise to be there for the respiratory patients. So our goal was to improve the outcomes of our respiratory patients through education, assessment, proper treatment, starting at admission through dismissal at the patient bedside. So how we started with all patients admitted on breathing treatments, but it is expanded to all patients admitted on oxygen and all patients that are screened with the modified dyspnea scale greater than 4. Again, these reports for the modified dyspnea scale comes to our printer, so we're identifying patients that may not be on breathing treatments, that may be having trouble breathing that we weren't being notified before of. So that helps us identify patients, go to the room and do an assessment, and determine if respiratory needs to be involved with that patient. This happens to all patients admitted to the hospital, and all of our patients that are screened are seen by an RT, and all of that are on respiratory treatments then are assigned a primary care therapist. So even though they've been admitted maybe just on oxygen, a therapist goes to the room and assesses them, and a lot of times we can determine if they're a patient that's been on treatments at home and they continue to need them here at the hospital, but they haven't been ordered, so that is helping us catch those patients as well. As we move on to further out how we rolled it out, then we have basically a unit-based counsel in the respiratory department, similar to what the nurses do for their areas of work. We developed an interview and assessment tool, and we decided within 1 hour of admission of all of our patients on breathing treatments, the respiratory therapist would be at the bedside and do an extensive interview and a patient assessment to that patient. And they would be assigned to that patient throughout the stay. Because we have flexible scheduling and a small staff, we needed to make sure that we were communicating well, not only to the respiratory therapist, but also to the nursing staff about our plan of care. So we developed in our department, we have a master worksheet as well, but we also developed who's the primary care therapist and any goals that we might have documented on that master worksheet. So whoever picks up that that treatment knows who the therapist is and what we're working on. So our message is consistent throughout their stay, and we're working on those weaknesses we may have found during the interview. Specific educational needs are addressed by the ancillary staff. Like if we need to get, say, dietary involved, we communicate that need with them as we're interviewing that patient. We also communicate directly with the physicians. We either call them by the phone or we leave there's a communication sheet on the chart, and we get things changed. In our report, we do an extensive report, but we also have what we call little mini huddles throughout the day, and we report on, after rounds, anything that it's kind of like a brainstorming time where all the therapists are together and we can brainstorm on that particular need for the patient if we're addressing everything. We recently started distributing business cards with our logo, our name and logo and our phone number on it to the patient and their families, so we can be easily identified if they have questions. And we also communicate the hospital-wide whiteboards that are in patient rooms who to call if they have a respiratory issue. So both the nurse and the patient and their family know that we're there to help them. We also implemented our discharge planning group. Recently went to 5 days a week, and that's the group that meets every day at 10:30 for an hour about all the patients in the hospital, and we decided we needed to be at the table. And so one RT staff attends that discharge planning meeting on all patients 5 days a week and communicates not only what we're doing in respiratory with their patients, but also finds out things that we may have missed and we're able to take back to our RT team. We do have a program for high-risk patients. They're referred to, it's called the AIM program. And this program is funded by the foundation as a trial program through the hospital where home health nurses are going to follow up those high-risk readmission patients at home. And so one of our staff attends those meetings, and we all refer COPD patients that are high risk to that committee so that they may be seen at home. So we're hoping to get a channel that we actually have someone at the home later checking on that patient. And that's been a lot of the patients that have been on the AIM program are the patients with COPD. Our physicians are notified directly with our communication, either through the electronic record or on the communication chart. We do a lot of calling physicians one-on-one and inform them of what we need for this patient or how we want to change things. We also, on an admission, do a primary care worksheet. As we're doing the interview with the patient's contact information, any pertinent information that we need to follow that patient home with, and we have staff do follow-up phone calls within 24 hours of dismissal. And this is something done by each staff member because we felt like it helps the staff member realize any weakness they may be doing in their interview process or their assessment skills. It builds a bond with the patient. They have someone to connect to, especially since we've been using the business cards. They recognize names, and it also helps the morale of the RT staff because they feel valued and the patients recognize them. Because we're not included on patient satisfaction surveys in the hospital-wide setting, this gives us a way to track that satisfaction of our patients that are involved with respiratory therapists. And that is, again, a good morale booster for us. The benefits that we see from this, the patients receive the needed education by the primary care therapist, and with this model we receive individualized care plans for specific findings, so we're able to individualize each patient's care while they're here at the hospital, and we recognize any weaknesses or any problems they may have outside of the hospital where we can get involved with social services or financial office or that. So that kind of individualized plan is important. The staff gives the same message to the patient through the education because we're all on the same page about that patient and we communicate regularly and we have a primary care therapist. We address that weakness while they're here at the hospital. So if they're having trouble, say, with their MDI application, we can make sure that that patient knows how to do it before they leave. And again, we use communication during report, our master list, and then our huddles throughout the day to accomplish that. We have flexible hours of staffing, so staff is coming and leaving at different times of the day. There's no kind of regular schedule because we want to be productive while we're here. So that huddle is frequent, but I think it's very important to get that communication through. Our patient satisfaction then is tracked with our respiratory patients, and we can do that with our follow-up phone calls, and we can address problems quickly within that 24-hour period and hopefully prevent that readmission rates. What else happens? Well, the staff competency and confidence improves with these. They have better assessment skills and education skills. They're actually, out to find ways to improve patient care. Staff becomes more of a patient advocate. We do have physicians that don't understand some of the recent medications and processes or the treatment for respiratory, so they become an advocate for the patient, and they become the voice for other caregivers and the physicians, and they communicate that to those caregivers. Our staff morale improves because we have better teamwork and better communication, and our staff is at the bedside more, taking care of the patient and addressing their specific needs. I think the ancillary staff appreciate the RT skills more, and the RT staff becomes more valued because they're calling us more frequently to help assess the patient's needs. And in the long run, this helps the RT staff because they're willing to take on more projects as we come up with them. One big thing that we've seen just since we initiated primary care therapists is our readmission rates for COPD have improved from the first quarter of 2013 to the second quarter from 18% to 4%. These are just all COPD patients that are readmitted for anything, but we are tracking in our department just the COPD readmissions, and we have a big board in the department that tracks the number of days without a readmission, so we're up to 53 days today, and that kind of builds. The staff walks by it every day, they see that, and it's a challenge for them to keep that number growing. Our length of stay decreases because we're at the bedside within an hour, and we're initiating and recognizing the appropriate care and getting that patient started on the right treatment at the right time and getting them so that they're hopefully getting out of here quicker because we're identifying problems before they happen. Our patient satisfaction, again, is measurable, and we can track it within the RT department. And I think that's a great morale builder for the staff. I think that administration takes notice and are willing to listen to us when we have other projects that we think we can initiate with the staff we have. Some of the roadblocks that we've had, again, it's not something that happened overnight. As I stated, we started small and built on it. We want to continue to build on our skills, and time for education has really been the biggest problem for us. Sorry, my phone's ringing. The biggest problem for us, but what we're doing is trying to do it with email, webcast, online education, competency, and department meetings. So we try to incorporate a lot of this within the meetings we already have. And we're assigning staff to different committees to be part, so they get the whole picture of the hospital too. Used to be that I went to a lot of the meetings, but now I'm kind of giving each staff an assignment, and they have to develop it and go with it. So I think that helps them buy into the whole hospital wide, and it helps with their education. Productivity, again, because the things we do don't count for productivity when you look at the standards of how we're counted. It does allow administration know that we're making a difference, and it kind of allows for those variances in productivity standards if I can prove that we're making a difference with that patient. The small staff, it is a challenge at times. Right now I have 2 out on FLMA, so that is difficult to try to keep everything on track and keep the program going, and communication is really the key. I think our small huddles throughout the day, it's 5 minutes before lunch or 5 minutes before the next shift, when the next shift gets here, or it's just, we sit down, we need a huddle. That's important to do. And even we have more intensive report, those huddles help us keep focus for the day. And then we come to what do we give up? We're trying to look at what really makes an impact. So we want to try to give up the small stuff so we can make a big impact on length of stay and readmission rates. And as our staff, I think, has gotten better, we're not there yet. Good is good, better, best, never let it rest until our good is better and our better is best. And I think that's how we keep looking and keep moving forward with this. We have a lot of ideas for the future. Not sure how we're going to handle that, but I think now we have buy-in, we have the skill, we have the competency of the staff. I think we can accomplish a lot of great things with that. And I do have this, I will be posting each of the programs in detail on AARC Connect best practices. So if you I haven't got them there yet, but I want to go through how we developed the OSA screening, how we developed the smoking cessation, and how we developed the primary care. So those will be available to you.
Thank you so much, Karen. That was absolutely fantastic, and I'm glad that you reminded everyone that on AARC Connect, which everyone who is an AARC member has access to, we have this community. It's free to join. You can get access to all this awesome information and dialogue with others about this program, so please don't forget that valuable tool. Karen, you did a phenomenal job. We really, really thank you for this session. Unfortunately, we're a little low on time, so there were some phenomenal questions that I don't want to let go. So what I'm going to do is send Karen those questions, and then when we post the archive, we'll post a response from Dr. Schell to those questions so that those can get answered. So do check back with the archive. And Greg, I will turn it over to you. It's okay.
Thank you, Shauna and Karen. And our third speaker is Karen Sicard. Karen is a respiratory therapist and clinical specialist in respiratory care services at Wellstar Health System. She has been with Wellstar in Marietta, Georgia since 1988 and manages the Breathing Easier program. Karen?
Hello, everyone. Thank you for this opportunity to share our progress in our Breathing Easier program. We started it actually in 2012, so it's a very young program with big plans to expand. Let me share some of the things from where we started. We have morphed our way all the way through this year and adding different pieces to it and improving our process to make a seamless flow for our patients. This is a program we started here at the Wellstar Kennestone Regional Medical Center. We are part of the Wellstar Health Center in the northwest section of the Georgia area, just northwest of Atlanta. We're a 633-bed hospital and an ACO participant. We have a respiratory department here at Kennestone of about 120, I believe, RCPs, and we average probably staffing between 17 and 20 therapists per shift. So it is a large facility, and even with all of our resources, we still stumble across good staffing as things peak up. As changes came about, and you all are aware, which is why we're speaking today on the readmission reduction programs, identifying the pieces to decrease. Wellstar had already put into place the acute MI, the heart failure, and pneumonia reduction programs, and looking forward into the COPD programs, we needed to get in gear and find out what we could do for our patients in our community. The national reporting, as was stated already, the 30-day readmission rate for COPD was at a 22.6 for the MedCat statistics. Our pulmonary service line is a Wellstar multidisciplinary team, which is what we used in development of our Breathing Easier program. It goes across the 5 hospitals that we have in the Wellstar system, our physicians' offices, and our clinics. But we pulled the team together of our administrators, care coordination, home health, our nursing staff, physicians, respiratory therapy, and our quality team to take a look at what we could do as we were charged with implementing a readmission reduction program. We decided, the team took a look at what we're what hospital would be the best to facilitate our pilot, and that's how we came up with our Kennestone program, and looking at our pulmonary unit as our pilot. When we first started our program, which was targeted for 112, we had a 24-bed, one unit, and then I think it was January of 2013, our pulmonary unit expanded up into a second floor, so we're up to a 48-bed pulmonary acute care unit. The background that we had looking at these patients and readmission, our baseline for an all-cause readmission, and all-cause being the fact that you may come in with a pulmonary or a COPD primary component, and then if you're readmitted within 30 days for any type of other readmission complication, you fell into our all-cause readmission. We also took a look at our COPD to COPD readmission to make sure that we were kind of tracking everything that we need to, and everything we were putting in place for our population group was making an impact on the overall. We also do a premier benchmarking rate and took a look at where we needed to be, and you can see that we were off on our all-cause readmission much higher than we wanted to be on our benchmarking. Our COPD readmission was less than our benchmarking. However, we still wanted to make sure that we were doing the best we could. So graphically taking a look at it, month to month, you can see we were all over, no big consistency, except the peak times seemed to peak for both of those things, and all-cause readmission in the red and the COPD readmission in the blue. Our team, our pulmonary service line team, got together and decided we needed to take a look at how we were going to go about implementing our Breathing Easier program, which at that time didn't have a name. We were just focusing on our COPD folks. But we wanted to make sure that we focused on the person. We had to look at our data, which I just demonstrated for you. We wanted to make sure that we had something that went across the continuum of care, not just in the hospital, but we wanted to make sure we reached out into the community side and followed the patient straight through. We knew we had to improve our discharge process and best take a look at our high-risk patients that are impacting our readmission rates and make sure we engage patients and family members. So we adopted, which probably looks familiar, this is from the Pittsburgh model for readmission, and we researched all areas around and what was going on and decided in the WellStar system we were going to adopt this same type of flow process. And this was going to be our challenge, to take a look at the admission program, identify the patient when they come into the hospital, COPD protocols, treat exacerbations. We already have in place in 2002, we implemented and have been running for the last 11 years an assess and treat program where the therapist goes up and on admission, assesses the patient for appropriate therapy, places them on the therapy, and makes adjustments to either frequency or therapy, or transitions them either to the MDI modality, or if the patient should increase severity or exacerbation during their stay, they can escalate up the care of the patient. So we have those pieces in place. We do have a COPD admission, best practice admission order sets, but we needed to really dig down deep into our root cause analysis and improve our discharge plan. So taking a look at this, we moved forward in our process to find out how are we going to make this actually happen. We were not getting any more staffing anywhere across the system, so we had to use what we had. We had to develop our team, decide who was going to be our team lead, and respiratory became our team lead in this project. We had to identify role responsibilities. We had to do a standardization through the continuum of care of our education tools. It was a requirement that we developed education that can be used in hospital, in the physician's office, in our pulmonary rehab unit and used in the home areas in our clinics. So we had to research all of those and develop all our tools that we would use for the patient. Communication, developing good communication from the inpatient side to all the team members. And you're looking at your nursing staff, your coaches, your discharge planners, and even your community side. We had to make sure what was happening in the hospital was easily communicated, and the needs of the patient was easily communicated to the home health and the community coaches that we had in place already. So here we had in the hospital, we had our therapist, which we dubbed the name of our RT educator. We're not calling them a COPD because they actually were focusing on a lot of education, but as we've morphed through the year, they are focusing mostly on our COPD to help keep our COPD readmissions down. We have our nursing staff that is working with the patients on our pulmonary floors and making sure that they reiterate the education that we're doing. We have a discharge planner that would help set up and make sure that our patients had everything that they needed at home. So we had to figure out how to tie all these pieces together and make it move smoothly across into the community, where we had our pulmonary medicine group. We have an ACO coach, chronic care coach, which actually would take those very high-risk patients, not just COPD, but diabetic, heart failure, anybody with a multiple problems, medical problems. They would then follow and track those patients through life until no longer needed, not just the 30 days. We have the pulmonary rehabilitation program and our home health COPD program. And in our home health COPD program, we have an RT and who is also an RN that focuses on our COPD patients once they go home. Within 24 hours, her job is to make sure that she goes and sees the patients and works with them on their COPD progress. Our pulmonary rehab program is also with RTs, working with them through their different phases of rehabilitation. Next, what we did is we took a look at what our patient needs are, and our nursing staff and our discharge planners did a survey of our COPD patients as we prepped up on how we were going to approach our patients to find out what their needs. And the outcomes of those was huge in the knowledge deficit, disease process, symptom recognition and management, and medication management. The therapists were dumbfounded when they would walk into the patient, and patients they had been treating for years, that they assumed they knew what their medications were for and how to use them. When we actually started doing our education, we found out that there was a huge knowledge gap. And that's exactly what the patients told us in this survey, that they quite didn't understand that. On the discharge planner side, and taking a look at they surveyed and took a look at those patients, and the big key things there were financial. They didn't have the finances to either get their medication, follow through with their physician's visits afterwards, and they didn't have caregivers, primary caregivers, and as I stated, they weren't following up with their physicians post-discharge to make sure. And those are all pieces of compliance when you're trying to do a self-management program for these patients. So we decided we could tackle these pieces in the red. They were our big challenges. We had players in place, and we were going to go ahead and march forward with this. The prompt follow-up and phone calls, really, we didn't have anybody to take that on, and that we took into our COPD educator was going to tackle that role. We identify the patient. We had to take a look at when the patient enters into the hospital. Currently, we use a system that isn't very good in communicating. It's a McKesson system, and I hate to say that, but we have the discharge planners are using one system in a canopy. The clinicians are using a different system in the McKesson for documentation. The physician is out in his office using another whole computer system. So our communication phase in identifying our patients and getting our information really became a huge obstacle when we started up. What we did is the respiratory therapist became the initiator of the program and really is the one that channels and funnels these patients through the whole process. They'll identify the patient on admission. We learned the discharge planner computer system, which is called Canopy, and that system itself, we were able to see the admission diagnosis, follow when their last admission was, know if they were a high risk for readmission. The patient fell into our program for doing our Breathing Easier program. The bedside therapist would continue on with the proper treatment. The physician's order set are in place for COPD. The treat exacerbation with the therapist doing assess and treat. And the RT educator would then approach the patient, introduce and move forward with the root cause analysis for their readmission. Why were they brought back in? And then that information funneled over into our rounding program, which then in communication to the nursing staff, to the care coordination on what we needed to do to get this patient ready and prompted for home. Follow-up phone calls also came into the RT position initially. We followed those, and then we had to kind of transition, which I'll talk about later, due to the volume of patients we were looking at. And we had our ACO care coach at home. So our Breathing Easier, actually, when we developed our process, came into place with once we identified our COPD patient or the patient that we needed to see because they had multiple admissions for maybe shortness of breath, but you're not seeing COPD anywhere. So we would go ahead and screen those patients to find out were they at risk for COPD, and then we would enroll them into the COPD education or the Breathing Easier education using the terminology. The educators would make sure that they use the terminology of you're at risk, these are things you need to bring to your physician and check and make sure, but in the meantime you're on these medications. Here are some pointers that can help you get through your quality of life and get you back to work. These are usually our folks that were in a stage 2. We identified them mostly in our stage 2, maybe early stage 3, that hadn't even been diagnosed yet with COPD. But we would start out with our screen, enroll them, and then move into our pulmonary health knowledge. We wanted to make sure that the education time we're spending with these patients, they are actually grasping and making changes to their lifestyle. They're understanding those big gaps that we identified on our survey with them, and that they are learning things while they're here. You have just 4 days to try to implement this. We tried out our education plan on a 4-day plan, just an hour each day. And then we found out that the volume got to be so big, we actually had to narrow down to a 2-day. So we have our healthcare knowledge we did on admission, and then we would repeat those same questions on discharge to make sure that we had some increase in knowledge base there. We developed our Breathing Easier education booklet. It's a booklet that the COPD folks will get and those that are at risk will get. In working with them and making sure that they understand it's goes through multiple phases of care and self-treatment and why they need to do things. We developed an action plan, mostly a symptom recognition and when they needed to take action and what action to take. We developed a pulmonary needs education, and this was barriers to home. It was a form where the patient themselves would identify what are some of the barriers they recognize. And it would it was a picture type of thing where they would identify, are there financial needs, is there dietary needs, do they need help in making appointments, do they need help in getting medicine or even identifying what their medications are for. Do they have any home situations such as stairs or pets or children, grandchildren. Nowadays, there's a lot of elderly that are living with their families and younger children. And then you have the different reinfection rates with the younger children and viruses. So all those different things are we would question and ask them at their leisure to go ahead and circle and identify what their barriers were at home. So we made sure we hit those in our Breathing Easier booklet and made sure they understood how they could prepare themselves and make it better for themselves at home. COPD Teachback was a methodology that the nursing team developed a COPD workbook, so those patients that actually had a COPD diagnosis, they would then target those patients with a workbook that complemented our Breathing Easier, and they would look to see what topics the RT actually covered for that day, and the nurse would come in and reiterate with a teach-back methodology on those different topics. And then again, RT would handle the transition calls to home. On the discharge planner side, the discharge care coordinator would do a risk assessment, identify if they are a moderate or high-risk patient, and if they hit that moderate or high, those patients were automatically funneled into our home health program or to the chronic coach to let them know those patients are still in the hospital or in the hospital on a readmission and need to be seen and followed up once they get home. To take a look at our own personal RT process, we developed our own internal monitors as far as how many patients were re-enrolling, how many patients were giving us knowledge improvement before discharge, and were we able to complete the Breathing Easier education prior to discharge? Did we need to shorten, which were one of the outcomes that we did as we moved through the process. Instead of a 4-day, we broke it down into a 2-day. Post-discharge calls when we were calling. We wanted to know how many patients we're actually able to contact. We would ask them, did you get your prescriptions filled? Are you using a medication schedule, so that they kept reminding themselves when to take their medications for what actions, and were they using their action plan daily? We also had a Press-Ganey survey that we had a question on there. How did your respiratory therapist, were you satisfied with your respiratory therapist care that was given to you while you were in the hospital? So we were tracking that to see, did we see an increase in at least the patient satisfaction while they were in the hospital? So those were our internal things. Taking a look, this is really what we came up with. Our Breathing Easier booklet went down through these pieces within our booklet. And again, the action plans outlining what they needed to cover. Our therapists really focused a lot on the COPD causes, or still, sounds past tense, but they are still working with the COPD causes, symptoms, and their management of it, focusing on the action plans, their medications, breathing exercises, stress and panic attacks. We find that those are some of the key things that really help these patients understand what they need to do. Smoking cessation is in there, but we left smoking cessation education really heavily onto the nursing side because we wanted to make sure that the patient was hearing us as far as how to manage their respiratory therapy. We do go through smoking cessation, how important it is, but the actual things that they need to focus on is how to manage their care with medications, access to, and their panic attacks. As I said, nursing will cover the smoking cessation more heavily into it. The nursing workbook actually has the action plan zones, and it has a 6-week march out of a daily assessment where much like the asthma zones, the patient has to mark out where they are in their zone for each day, and they're required to bring these booklets back to the physician's office on their first follow-up appointment so that it can be reviewed by the nursing and physician team when they see them. here's a good look at our action plan that we put in. And like I said, it's for self-symptom recognition and management. They need to take a look, ask themselves, am I in the green zone, yellow zone, or red zone? And, you know, their actions, what we found in the yellow caution zone is they really didn't feel that bad. It really didn't warrant a call to the physician, so they weren't really going to call them, and the next thing they knew, they were in the red zone. So a lot of heavy education to they need to take action and call their physician. The physician's offices had to make sure that they were in line with ready to accept all those phone calls as they funneled in on what they needed to do. Our discharge process, our care coordinator, as I said, would do the risk assessments and taking a look at, this is all happening all within the first, I think, 24, 48 hours of admission, assessing their, all these different pieces, identifying their low or high, and again, ensuring that these patients were either enrolled or the community coaches were notified that these patients are still or admitted once again or in place. One big thing that we had was the communication was most key to this huge process we were putting in place, especially since our computer systems were not crossing well. It was very difficult to touch base with everybody that needed to be into the program. So what we have is doing pulse checks. We would meet weekly with our team, our educators, our nursing staff, our coordinators, our care coaches, and make sure that we were all following things well. We knew what was going on, how to manage those patients, what we could do to improve on those things and make sure that we had some standardized communication straight through. The thing that we needed to do is recognize that for respiratory, it was very difficult for the volume of patients that we were seeing to be able to manage the admission, locate and admit our patients and screen them and educate them, and then make sure you did your callbacks, because our callbacks were happening at 24-hour callback. They were happening at 1 week, 2 week, 3 week, and 4 week. So you had people at different points that you had to make sure that you touched base with and made sure that everything went well. So we needed to look at transitioning some of these responsibilities so that our patient had the best care they could possibly get. Looking at the start where we had our timeline of evolution of our program, we started out with RT doing the education, doing the post-discharge calls, referring patients to our pulmonary rehab, and actually making communication to making sure that there was documentation that was easily picked up in the canopy, the discharge planner's notes for the community care coach to pick up. Nursing doing their teach back came into play in the March area. In August of 2012, our whole system got together and realized there were too many departments making phone calls to our patients, and there was a lot of dissatisfied patients in how many calls were coming from their WellStar. So we went to a centralized call, and this came from our Discharge Summit program that we had, and we moved to the 24-hour call would go to the discharge call center. We were able to get a COPD advocate, which was actually one of our RN discharge planners. She would take over the movement into the community side, and I can see I'm talking a little long, so I'll hurry up. We also added into our program was a CTTS, which is a community-based care transition program, a government-based grant, where they also would add on doing the COPD patients. these are some of the outcomes that we had, and we're moving through. You can see in tracking ourselves through it, we really didn't have a baseline because we started out brand new. 78th percentile was for our customer satisfaction. We started to really increase, and you'll see a big dive in here, and that's when we went into a staffing crisis in our hospital. We had too many people out on leave. We had to pull our educator, and things kind of went all in different areas, but our discharge advocate and our nursing staff stepped up to make sure that we were able to reach our patients. This is the outcome on just our pulmonary floor, taking a look at where we were. You can see our green line is our benchmark, red being our outcomes post our breathing easier. We really started to make an impact, still seeing the big peaks that we saw, again, at the same times prior to our discharge. COPD or breathing easier program. This is taking a look at our COPD readmission, as we just saw in our all causes in comparison there. Our all causes is what we really want to make an impact on, but making sure that we within our own program were making a hit, and we are starting to make some steady decreases in that way. Here's our overall in the hospital. The prior slides were really for our pulmonary floor, but you can see we are having, in our 1 year's time, we are showing a gradual drift downward where we are decreasing. Our initial baseline for COPD to COPD was 6%. We're down to an admission rate now of 3.8. On our overall all-cause readmission, we were starting out at 20.31, and we're now down to 18. We're still higher than our benchmark and need to work on those areas. So as we start to move forward, again, the blue is all the areas that we have improved on. The yellow are the areas that we're starting to merge into now, reaching out to our nursing homes. Our emergency room is kicking into place where we'll be able to our next steps work with medication access for still those folks that are having financial needs and difficulties. We're also looking at trying to get medications or getting medications to our patients prior to discharge in the hospital from our pharmacy within. We're going to have respiratory therapists providing education into our community areas, being a go-to person. Our emergency room passport program is going to also our nursing homes assisted livings, where they'll be able to register the patient. As soon as they register the patient at these facilities, it'll pop up into the ED, and it also will flag the discharge planner, and the discharge planner can then recognize in the ED that this is one of our COPD patients. And we can start our education immediately right down there. One good part also is that we're moving to EPIC, and our Keystone facility will be moving to the EPIC, the electronic medical record, which will help our communication tremendously come December this year. So I just want to thank you all for being patient while I went through those things. We're moving forward and continue to move forward in our program.
Thank you so much, Karen. This was, again, this is just a phenomenal program. In the interest of time and our next presenters, I want to make sure that they have plenty of time to provide their information. Again, what I'll do is take the questions intended for Karen, and we'll add those to a script that will accompany the archive, and we'll let you know when that's up, and we'll also post some information in that best practices group on AARC Connect. Greg?
Thank you. Our final speakers join us from UC Davis Medical Center in Sacramento, California. Michelle Young and Crystal Craddock are both respiratory therapists and are case managers at UC Davis Medical Center. The UC Davis ROAD program was conceived to heighten public awareness of reversible obstructive airway disease by simplifying patient education and coordinating access to primary and subspecialty services for patients and their families. Michelle and Crystal.
Thanks, Greg. The UC Davis COPD case management team is made up of 5 registered respiratory therapist case managers. All of us went to the AARC online and took the COPD educator course. Crystal and I are the 2 full-time case managers, and we're happy to share our program with you all today. ROAD stands for Reversible Obstructive Airway Disease. Recent research has led to the understanding that if patients adhere to an appropriate COPD medication regimen, there can be some reversibility in airflow obstruction, and participating in a pulmonary rehabilitation program can reverse many limitations patients feel encumbered by while living with COPD. It is estimated that for the 12 to 16 million people diagnosed with COPD, there may be even an additional 12 to 16 million people that are living with this condition and are unaware of it. Severe exacerbations really account for a great deal of the cost for treating COPD, and COPD is associated with the third highest readmission rate after 30 days of discharge. As we all know, there's going to be some changes in Medicare reimbursement for the cost of hospital admissions for patients who are readmitted for an acute exacerbation of COPD within 30 days of discharge. It was brought to the attention of our Respiratory Care Department Medical Director, pulmonologist Dr. Sam Louie, that the readmission rate for AE-COPD at UCDMC was 16% in fiscal year 2011. The idea for a program to educate and treat patients with COPD was developed by Dr. Louie. He wrote a grant proposal to start up the program, which is now an integral part of our Respiratory Care Department. Little back history, in 1999, Dr. Louie started the University of California Asthma Network, or UCAN, to decrease ER visits and hospitalizations of poorly controlled asthmatic patients within the University of California Davis Health System. RCPs provided acute care in the ER, assessed, educated, and followed patients with severe asthma to the outpatient UCAN clinic. This was hugely successful, and from May of 1999 to August of 2001, the UCAN clinic treated 162 patients in an outpatient clinic by referral, and this group accounted for 318 ER visits and 114 hospitalizations for asthma in the previous 12 months before the UCAN clinic was started. The outpatient education and combination controller therapy actually reduced the need for ER visits by a little over 90% and hospitalizations by about 96%, with obvious cost savings. Our only inclusion criteria is that to receive our COPD education services, patients must be admitted for an acute exacerbation of COPD. We've been implementing a screening tool that took us about 5 months to get just right that generates a list of patients in the hospital that meet about 5 specific criterion to be populated on the list. We also have referrals from other respiratory therapists, nurses, physicians also contact our program to enroll patients. We have identified a few clear exclusion criterion as well, which we consider on a case-by-case basis. If a patient does meet our exclusion criterion, we still reconcile respiratory medications, and if any changes are made or recommendations made, we will see the patient for a one-time education session to discuss an overview of COPD and the new changes to medications made to the COPD regimen. When we accept a patient to receive our full education services, we reconcile their medications. We evaluate their inpatient regimen for effectiveness and treatment of the acute phase, and we assess their home regimen for appropriate transition once the acute phase has passed prior to discharge. After we reconcile medications, we educate the patient using scripts as a guide in 4 sessions no longer than 1 hour in length. We use educational materials such as colorful visual aids, lung models, handouts, and videos. For the medication session, we also use inhalation device demos for instruction on proper technique with return demonstration by the patient. Throughout the length of stay, the floor RT will follow up our education sessions with reinforcement of proper medication administration technique until discharge. We, as RTs, head this multidisciplinary team during admission and also keep in communication with the discharge planner to assess any discharge needs prior to their return home. We really try hard to keep in mind this model for adult education retention because we do see such a huge demographic of patients coming through our hospital. We really want to make sure that we can kind of reach each patient on their own particular learning or meeting their own particular learning needs. So we try to make sure it's really diverse using a lot of tools and really just keeping this model in mind. And then I'm going to hand it over to Crystal to discuss the real meat and potatoes of our program.
Okay, so education session, we tried to split up our education into 4 days or 4 sessions. Our first session, we go over what COPD is. We ask the patient, do you know what it is? Do you know what it stands for? We use terms to help the patient understand COPD. We go over anatomical alterations caused by COPD. We talk about how the lungs work, gas transportation, and how COPD is diagnosed. Then we discuss the treatment options with this, for COPD based on the severity per GOLD guidelines. We go over medications used to treat COPD and discuss them by classifications in this medication session. We go over what the difference between maintenance medications are and rescue medications. The patient needs to know the difference, know that they need to use their maintenance medications every day no matter what, and the rescue is just for when they're short of breath, so that the patient understands all that. We use whiteboard illustrations, lung models, and videos. For education session day 2, we focus on the patient's specific medications that they're taking while they're admitted here and what they take at home to manage their COPD. We want to evaluate the patient's inhaler technique. We want to make sure they have a great inspiratory flow and can perform a breath hold. If we find that they cannot do a DPI or an MDI for whatever reason, we will switch them over to nebulizers if they need. We want to make sure the patient is getting their medications, and we want to make sure the classifications of their medications are correct for their stage of COPD. We also recommend the regular use of acapella or any other PEP device for mucus clearing. Our hospital just happens to use acapella. In addition to our medication evaluation process in-house, we identify additional equipment that may need to be used at home, such as a nebulizer machine. And for our third education session, which is by far our longest, we discuss the importance of early signs and symptoms of a COPD exacerbation versus experiencing a bad breathing day. We want the patient to know the difference. They need to know, is their work of breathing increasing? Is their sputum changing? We go over their, in particular, triggers, what causes them to have a bad day, whether it be heat, bad air quality. And we tell them that if they're experiencing early signs and symptoms of an exacerbation, they need to get a hold of a case manager or their primary care doctor as soon as possible. We teach them how to measure their heart rate and respiratory rate. We go over controlled breathing techniques, pursed lip breathing, diaphragmatic breathing, and tripod breathing. Coping with shortness of breath as well. The dyspnea cycle, when a patient is short of breath, they get anxious a lot of the times, which causes them more shortness of breath, which will cause more anxiety. So we go over relaxation techniques and stress management techniques. We talk about preventing infections, staying away from sick people, washing their hands often, getting their flu and pneumonia vaccines when needed. Also during this education session, we go over pulmonary rehab. We refer or try to refer all of our patients over to our pulmonary rehabilitation program here at UC Davis, which has actually grown from a 3-day-a-week program to a 5-day-a-week program now that we have this COPD case management program going. We've been able to increase their numbers over there, which is great. Some of our patients that are still smoking, we refer them to smoking cessation program. We perform our own motivational interview regarding smoking cessation, and actually we've had about 10% of patients that we have seen who are current smokers on admission who quit smoking after their first encounter with our program. On our last day or education session is when we give the discharge instructions for our COPD patients. We reiterate quitting smoking, avoiding infection. They need to take their medications as directed, different stress management techniques, and we want to make sure they're going to make a follow-up appointment with their primary care doctor after discharge. We also go over home oxygen, whether the patient's on it or not. In the future, their disease might progress to where they will need home oxygen. So we go over the delivery device systems, oxygen safety, traveling with oxygen. During this education session, we also do the stop bang questionnaire with the patients to assess for the risk of sleep apnea. If they are at high risk, we then discuss with the hospitalist or the gen med team to refer the patient for an outpatient sleep study upon discharge. Follow through, we call our patients 3 to 5 days after discharge from the hospital. We want to make sure their referrals for smoking cessation and pulmonary rehab and the sleep lab have all been handled if they needed any of those referrals. Did they make an appointment with their primary care doctor yet? Their discharge medications, we want to make sure they went to the pharmacy and received or have all of their home medications for their COPD that is on their action plan that we give them upon discharge. We question, are they taking their medications? How often? What are their medications? We just want to make sure that the patient is adhering to their medication schedule and taking them as prescribed. So our results for our program, the average length of stay for our exacerbation has reduced since the beginning of our program in March 2012 till about March 2013. We've ran these numbers. Our length of stay decreased to about 2 days from fiscal year 2011. Our readmission rate within 30 days went from 16% in fiscal year 2011 down to 5%. And as I said earlier, 10% of our patients who were smoking quit smoking after discharge.
And thank you. And we can open it up to questions if there's time.
Thank you very much, Michelle and Crystal. That was fantastic. Because we're a little past time, and I know that a lot of folks are needing to get back to work, I think we'll go ahead and end it there. But I do want to remind everyone that we will post an archive of this within a couple of weeks, and we will add this to the to our archive as an attachment. I also want to remind everyone not to miss at the 2013 AARC International Congress in Anaheim, California this year. Don't miss Stephen Jenks, our keynote speaker. Stephen Jenks is was instrumental in this whole readmissions initiative and is the former Assistant Surgeon General. So he's going to be giving the keynote, and we are absolutely interested in what he has to say and his insight. So Greg, I will turn it over to you.
Thank you, Shauna, and thank you to all 5 of our presenters today for sharing their time. Did a great job, and sharing your talent with us to highlight how a COPD disease management program can benefit our patients. For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you're watching this program as an archive, this concludes our presentation.